Welcome to my world, another day, another time, another period for knowledge acquisition. Knowledge is power, health is wealth. Today's topic is diagnosis of tuberculosis from pleural effusion. The first question I know you would ask is, what is pleural effusion? Pleural effusion is that fluid that occupies that cavity, the space between the lung and the wall of the lung. So the problem is that when there is infection or inflammation or even cancer, there is always that production, that reaction of a fluid. It could be increased and thereby displace the lungs, creating that symptoms, that problem of the patient not breathing well, coughing, and you experience non-productive cough, but it's usually very discomforting, landing eventually in the hospital. So this examination, I shall be making effort at helping us look at problems that are causing these cough, non-productive cough, that you might be suspecting tuberculosis, and it could be tuberculosis, and other infections that are likely to be gotten from pleural fluid. The diagnosis is expansive, and that is why you need to know. I shall, from the next production, try and answer some questions thrown at me, not on this YouTube platform, but personally, and see what interest it could generate in my viewers. If you like my production, press the like button, subscribe, and surely the quality of my production will continue to improve. The objective: to create the necessary awareness of pleural effusion and its associated causative agent that could be differentiated from tuberculosis pleuritis with laboratory tests. Introduction. Normally, the pleural space is lined by thin film of fluid in order to reduce friction when breathing. But when excess fluid accumulates in pleural space, it is called pleural effusion. This excess fluid could be as a result of transudate, which are due to hydrostatic pressures changes, as in congestive heart failure, cirrhosis, and hypoalbuminemia, or by exudates. When you talk of exudates, you thinking of inflammation, malignancy, rheumatoid arthritis that could even produce cholesterol. When we talk about pus, you are talking of pathogenic organism from infections or blood from trauma, cancer, and all these are what usually cause that pleural effusion. Yeah, let us talk about sign and symptom. One experience difficulty in breathing, acute illness with fever, chest pain, dyspnea, and a dry, non-productive cough. The chest pain associated with pleural effusion is caused by pleural inflammation of the parietal pleura, resulting from movement-related friction between the two pleural surfaces. Also, the bacterial infection could also cause damage, injuries, or when you talk of trauma or cancer, they could also produce that inflammation that builds up the fluid. The build-up of fluid presses on the lung, making it difficult for the lung to expand fully. This can make you more and more breathless, even when you are resting. Let's look at the pictorial expression. You can see the shape as is labeled. The trachea is where the windpipe is. The wind comes in, and the pleural is as labeled. That space is the pleural effusion, where the pleural effusion occupies at the bottom. It starts gathering at the bottom and pushing the lung up, squeezing the lung, and making it difficult for one to breathe. Yes, let's look now at the X-ray picture. You can see the picture of the lungs to the left lung, which is looking as if it's on your right hand. It's now squeezed more or less and by the pleural fluid, whereas the one that is on the left, which is the right lung, is normal. So if you look at the bottom level too, the picture, you can see what could cause that irritation, cause the body to produce the quantity of fluid. It could also be bacteria. So the picture below is demonstrating the bacterial presence, which will cause serious irritation and invite the immune mechanisms, the inflammation, the fever, and all the rescue mission of the immune defense of the body. So when you are now talking of exudate, you get it from if it is pyogenic infection. But if it's mycobacterium, which is also a bacteria, it produces more of lymphocyte response and less of the exudate. So what you see is more of inflammation, though the fluid is there, but on examination, it may rather present a picture of non-pyogenic infection. Yes, ordinarily from the appearance of the fluid that is collected, the sample collected through the draining of that fluid, you can guess the kind of infection that will be there. This picture up shows the compressed lung and the collection of pleural fluid. The bottom picture shows the cholesterol. Cholesterol as what is the pleural fluid, that the content of that pleural effusion is just cholesterol, and is usually commonly found with rheumatoid arthritis, the inflammation that one would experience. So all the content of the fluid is very diagnostic. The appearance also of that fluid could suggest the kind of problem, the kind of causative agent there. You can imagine when the appearance is bloody, you can see blood, then you are suspecting probably trauma, cancer, and other things that could result in red blood cells being accumulating in such an area. The same thing when you have it pus-like, very much like organisms that you suspect. And if you look at it, this eosinophilia that is prominent, you start suspecting that it's more of a pneumonia problem. There are so many inflammation. You could also start thinking of malignancies and TB, tuberculosis. Yes, from all I've been speaking about, the diagnosis effort is more supposed to be concentrated on differentiating tuberculosis causative agent of pleural effusion from other causal agents. But there is no way you will talk and you want people to gain that without you wouldn't mention these other things. But nevertheless, our concentration is on tuberculosis in pleural fluid. So the fluid is collected using a procedure called fluorescentesis. The sample is examined under a microscope for sign of infection, gram stain, Zn stain, culture, and sensitivity. The white blood cell count and differentials are done to know the predominant cells, whether it's neutrophil, eosinophil. But if it's tuberculosis, mycobacterium, you see more of lymphocyte. The pH level is taken. The ADA, that is adenosine deaminase level, which is used to really identify tuberculosis when it is raised. Glucose level, protein level, and lactic dehydrogenase level is also. The cytology is also very important. There are situations where there is paragonimiasis, where it is more of a parasite infection mimicking tuberculosis, because it is inflammation that you see. You don't see more of any other thing but the lymphocytes, and probably the presentation is more of a TB. So many people have been treated with TB, dangerous drug, and they don't get better. So eventually found to be parasitic or fungal infection that is causing aspergillosis and that is causing all that serious pleural effusion. And that is part of what diagnosis is about. Diagnosis is about definitive, being sure, specific, and that's the effort. Finally, let us concentrate more on how the normal pleural fluid will appear when you want to examine it in the laboratory. It will appear clear, odorless. The specific gravity will be less than 1.01. The pH is normal level, a little bit shifted to the alkaline level, 7.64. Protein content of less than 20%, that is less than 3 grams per deciliter, fewer than 1,000 white blood cells per cubic millimeter. When you are examining the pleural fluid, you use the lactose hydrogenase test to compare the plasma level with that of the pleural fluid level. The cytology, that is where you collect the samples and stain, like in the histology laboratory. There will be no malignant cell present. But if it's a situation of tuberculosis, the ZL stain may not even show, because many at times you won't find it. But the AF, acid-fast bacilli, is a picture that confirms there is the presence of microbacteria tuberculosis. The culture takes a long while to grow. Protein, you find it high. And like I said, this is also useful. The protein, the adenosine, the aminase will be elevated. These are reasons for you to suspect that it is tuberculosis that you are dealing with. And the appearance usually straw-like. We can also suspect fungi, parasite, like I earlier mentioned, viruses, cancer, and other malignancies. So, coming gradually, we have reached the end, and not the end per se, because I want you to continue to watch my more videos on health matters on this channel. You can always check the past ones, so many, over 100 videos that you can cross and enjoy your health. Knowledge is power, health is wealth.